That's really kind of the push of the meeting too, is that this shared decision making, so that everyone's at the table and we're all deciding on this is the course of action that we're going to take. So,
but I mean,
the patient's
numerous research trials have definitely shown if somebody has written instructions, they're going to follow it. They're going to be more compliant with it than open-ended. So even though I started practicing and it was just incorporated in part of the diet, that is super interpretable. Incorporating in part of the diet for somebody that absolutely hates the food, incorporating in part of the diet probably means, okay, I'll maybe eat it if I'm forced to. But incorporating is part of the diet for a bunch of allergists that know incorporation is more on a regular basis, and we've got to actually define what a regular basis is. Otherwise, patients are not going to know, and that's the reason why we have to have these studies. And all I can tell a patient is we don't actually know if the LEAP study that's incorporated 2 to 3 times a week, 2 grams 2 to 3 times a week, was that the correct dose per se? Could you have done it less frequently? Should you have done it more frequently? That wasn't a dose finding study. So we haven't done dose finding studies to determine how low can you go. All we know is that the LEAP study worked and it had amazing results.
So the LEAP study is the learning early about peanut. I don't know if you know that, but it looked at the differences between kids in Israel and kids in the UK, and looking at the food allergy of peanut allergy, and same genetic populations but different incidence of peanut allergy. And the big difference was timing of incorporation of peanut into the diet. So in Israel they have these Bomba snacks that are kind of like Cheetos, but they have peanut on the outside, and babies eat them.
So it was pretty dramatic results.
Yeah.
I mean, the people they separated the kids into 2 groups. One was skin test positive to peanut, one was skin test negative to peanut. And we kind of thought that the kids that were skin test positive might be more likely of developing a peanut allergy. And so within each of those groups, they told half of them to avoid peanut and half of them to incorporate into the diet, and actually specifically gave them instructions to, most of them use Bomba, but I think they actually have a choice between Bomba and peanut butter, and just really they had the goal of 2 grams of peanut protein at least 2 to 3 times a week. And
so
then
2 grams is 8 peanuts.
8 peanuts. Yeah.
Which for a little person, that's a pretty big quantity.
Yeah, but with
doable.
peanut butter, peanut butter is the most concentrated form of peanut, so it's definitely doable to get it into the diet. And what they found is that the people that were at the high risk, so they were skin test positive for peanut that we thought might develop a peanut allergy, if they were in the incorporate peanut group, they were 8 times less likely of having a peanut allergy at age 5. Which is awesome, because at age 5 you're going to kindergarten, you're going to be out at school and stuff like that. So we don't want kids to be restricted in any way, shape, or form, obviously. And so just the less anxiety from the parents, and the less worry that everybody's going to have, and the more freedom that the kid has. And they're not going to have to ask for things, and they're not going to have to be worried themselves. So it was definitely a huge landmark study. Everybody should know about it, not just in the allergy world, but in primary care world too. Everybody needs to, because that's really what changed the entire thought about prevention and about how we incorporate foods in babies' diets, when we should incorporate them, when we should introduce them. And it's something that everybody should know. I don't understand why everybody doesn't know it yet.